Hello, everyone. Thank you for joining us today. We'll be starting in just a few minutes. We're going to give people a little bit more time to join, and we'll be back in just a moment. Good evening, everyone. My name is Eli Lamberson. I'm a physical therapist and assistant clinical director at our Park Slope location. I'd like to welcome back those of you who have attended one of our other webinars in the past, as well as welcome those who are joining us for the first time. We appreciate you taking the time out of your busy day to learn with us. For those of you who do not know who we are, SPEAR is a private practice outpatient physical therapy clinic that has been around for over 20 years in New York City. We currently have over 25 locations located all throughout the New York City area. We have successfully continued to offer in-person care through the COVID-19 pandemic, along with launching SPEAR Live for those who are looking to stay in and receive care using our telehealth platform from the comfort of their home. In our clinics, we are strategically going above and beyond the CDC guidelines to ensure the safety and well-being of everyone. You can find more detailed information on those safety measures by visiting our website at spearcenter.com. We are here for you in whichever way makes you feel most comfortable. If you are looking for individualized care, either in the clinic or through telehealth, please reach out to us at your convenience and we'll get you set up for an appointment right away. So we're very excited to be with you today to discuss management of Parkinson's disease, as well as the common symptoms, presentations, and treatment methods for this condition. As you can see, we are coming to you live from various locations and SPEAR clinics. And although we do not anticipate any technical issues today, please be patient with us should any arise as we navigate working through this technology. I want to go over just a little bit of housekeeping before we get started. Throughout the webinar, we want to hear from you. If you have any questions, please feel free to let us know your thoughts in the Q&A feature found at the bottom of your screen. Please take a moment to hover your mouse at the bottom of your screen and you will see a Q&A option pop up. That is where you will put questions and we will do our best to address as many of them as we can during the webinar. It is best to put questions in the Q&A section, but if you put questions in the chat feature, we will likely be unable to get to them during this webinar. For those of you who are watching through YouTube Live, we are monitoring the comments section there as well, so please feel free to type questions in that area also. Lastly, there will be times where multiple panelists are on the screen. For the best viewing experience, please select Gallery View at the top right corner of your Zoom screen, so you will be able to see multiple panelists at one time. So let's go over our goals for the day and what we will be covering. Today, we will be looking to understand common symptoms associated with Parkinson's disease, discuss the various stages of Parkinson's disease, list common medications of Parkinson's disease, discuss with you how physical therapy can benefit those with Parkinson's disease, discuss different treatment methods, and list any resources for further information about Parkinson's disease. Before we get started, I'd like to introduce our team of panelists, and now we'll be welcoming everyone onto the screen. So our presenters today are Ramneet Manri, a physical therapist here at our Park Slope location, as well as Keith Find, who is also one of our physical therapists and athletic trainers from our clinic here in Park Slope. Kathleen O'Donnell Pickert is an occupational therapist and certified hand therapist helping us with our Q&A today. And a fun fact for everyone, April is Occupational Therapist Month, so we want to shout out all our OTs out there. And then just a reminder to everyone, it's best to be in gallery view so that you can see everyone at the same time. If you've done that already, you should be able to see all three of us right now. Okay, so let's get started. Keith, Kathleen, and I are going to say goodbye for now, and Ramneet, we'll let you take it away.
All right, everyone. Okay, so let's sort of get into what Parkinson's disease is first. We'll cover the common symptoms of Parkinson's disease, and then we'll have Keith get into common treatments for it. So what exactly is Parkinson's disease? I'm sure that we've all at least heard of Parkinson's or might even know someone personally affected by the disease. It is one of the more prevalent and common diseases that affects movement within the US. We're not truly sure exactly what causes it, but we do know that there's a reduction of what we call dopamine in the brain, which leads to loss of both motor and non-motor function. Obviously today we'll focus primarily on the loss of motor function, but just to know that there are other systems that can also be affected. So when you think of symptoms, you can kind of refer to the acronym TRAP. The T stands for tremors, the R for rigidity, the A for akinesia, and the P for postural instability. So tremors are commonly seen at rest. So in the earlier stages, you'll generally only see these tremors on one side of the body, commonly seen in the hands, but can also be seen in the legs or in the upper lip or in the jaw. And these tremors at rest are a little bit different from what you might see in other diseases. So with essential tremors, you'll see more shakiness with movement. So for example, if a patient goes to grab a cup of water, they might start to tremble a little bit. Whereas with Parkinson's, you'll see tremors mostly when they're resting. A common type of tremor that you might see in patients with Parkinson's includes hill rolling. So if you think about taking your forefinger and your thumb and kind of rolling uphill between the two, you might see patients commonly doing that when they're resting. Rigidity. So what is rigidity? Exactly what it sounds like. So they're stuck in a rigid position. Specific muscles are stuck in contracture, and it's difficult to sort of passively stretch them out of a specific position. For example, if a patient has rigidity in their biceps muscles, it might be hard to sort of push them passively into extension. This is also seen more commonly earlier in the disease and then starts to worsen once the disease progressively worsens. Akinesia, so A means without, kinesia, movement, so without movement. More commonly, we'll see bradykinesia. Brady means slowness, so we'll start to see a slowness of normal motions, which we'll sort of get into a bit more later. Postural instability is a common one, especially in the later stages of the disease process. So for example, there are changes in muscle tone, muscles that are responsible for keeping patients upright start to weaken, so they might not be able to stand upright as well as they used to be able to. We might start to see sort of a forward flexed posture. And eventually, we might start to see patients rely on stuff like walkers or canes as a sort of assistive device. Another very common symptom of Parkinson's is what we call festinating or shuffling gait. So essentially what that is exactly what it sounds like. patients aren't able to take full steps. So they start to take tiny, small steps and almost appear as though they're shuffling across the floor. So let's go ahead and get into the stages of Parkinson's. So we use something called the Hone and Yar staging system, or H&Y, in order to sort of stage these patients and see where they are along the disease process. Stages 1 and 2 are earlier on in the disease, usually about 5 years out from diagnosis. Stage 3, we start to see a bit more mild to moderate impairments. So they're a bit more reliant on assistive devices for standing upright, that postural instability that we were talking about. Forward flexed posture is common, so they can't walk or stand as independently as they used to be able to. However, these people are generally still pretty independent with their activities of daily living, so they don't really have to rely on a caregiver or anything like that too much at this stage. Once we start to get into the later stages of the disease, stage 4, we start to see moderate to severe impairments. So they'll definitely start to require assistance with standing and walking, and they might require some sort of assistance with their activities of daily living, or ADLs as well. And things that were commonly easy for them in the past, such as eating, walking, just becomes a lot more difficult. At stage 5, we'll generally see these patients in a wheelchair, so they're not able to walk at this stage. All right, let's go ahead and get into some of the medications that we might use to treat Parkinson's. So I won't get too much into the specifics of this, but I do think it's important for us to kind of touch on some of the side effects that you might see with some of the medications that are used. So if you are working with these patients, or you know someone with Parkinson's, you're able to kind of extrapolate and see which of these might be due to side effects of medication or which might be due to the disease itself. Most commonly, you'll see treatment with something called levodopa or carbidopa. Brand name is Cinemet. You could also use something called dopamine agonists. So remember, we were talking about loss of levels of dopamine in that brain. So if we use an agonist, we're naturally kind of boosting those dopamine levels up so that their movement system is a bit less impaired and they're able to move a little bit better. And then we also might use something called anticholinergics. So what are some common side effects that you might see? Things to keep in mind, you don't want to push these patients too much if they've just taken medications, because they might be experiencing fatigue, some GI symptoms such as nausea, vomiting, dizziness, and they might also demonstrate cognitive impairments sometimes. So there might be some confusion present, drowsiness, and if that's there, then you want to be a bit more cautious when you're either working to walk with these patients or just exercise them in general. So where does PT come into play with all of this? PT is actually one of the most widely used forms of allied healthcare for Parkinson's. And it's great because it can be highly individualized based on the individual patient. So we can take the patient into consideration, their goals into consideration. We can see what structures are impaired and therefore what sort of functional impairments that they might present with and we want to deal with. So I'll sort of get into like the general overview of how we might be able to treat these patients, and then Keith will come in with some fun specifics. All right. So a number of treatments do exist, and we'll talk a bit more about these in a bit. Some of them include Tai Chi, yoga, boxing is a good one, amplitude training, which we'll sort of get more into, and dance is also common. Cool. So earlier stages of the disease, so 3 to 5 years out from diagnosis, we'll see aerobic capacity affected. So we'll just train them in aerobics. So like we were talking about, we can start to bring dance and yoga and boxing into the picture, and just have fun with these patients. Don't be afraid to sort of push them outside of their comfort zone, because they do actually really benefit from the challenges that we can provide for them. Of course, still take safety into consideration, but don't be afraid to push them. Cool. Postural alignment and control. So like we were talking about, posture isn't too affected at this stage. So we can start sort of challenging them with higher level balance activities. We can consider single leg balance activities, again, as long as we're keeping safety in mind. We could certainly sort of push these patients at this stage in the disease. And once muscle strength and tone sort of starts to become affected, we can start to bring on treatments such as boxing and some of the other stuff that we'll touch on. Okay, so middle stages of the disease. So at this point, we'll start to see that bradykinesia that we were talking about, or the slowness of motion. So it might be beneficial to partner these patients up with either another patient with Parkinson's disease, or with a PT, or with an OT, and just get them to work with each other. If they start to demonstrate gait disturbances, so gait means walking or ambulation, it's very useful to use visual and auditory cues. So we want to start relying on external cues as opposed to internal cues. Basically what that means is if they're having difficulty bringing their hip or knee into flexion in order to, surpass an obstacle when you're practicing walking with them, instead of saying, try, lifting your foot up more, or try bending your knee more, you might want to say something more along the lines of, see if you can step with your foot over my foot, or see if you can try and tap your foot onto this yellow cone. That generally just works better for cueing these patients. Postural instability starts to become more of an issue here. So yes, we still do want to work on balance, except you might want to tone it down and just not keep it as high level as you would with the earlier stages. And okay, in the later stages, so working a little bit less on aerobic capacity and strengthening, and a bit more on caregiver and family training. So if they present with rigidity and their muscles are kind of stuck in a contracted position, thinking of passive ways to kind of stretch the patient, or positioning them in ways in which they're still using some of their muscles. For example, if they're going to be sitting in a wheelchair for a long period of the day, and instead of having them sort of sit with closed shoulders, thinking about having them activate their core muscles so that their chest is still sort of open and they're able to breathe a little bit better. Again, and just training their caregivers and families about how they might be able to help get them positioned in an optimal alignment. And then for postural instability, it might be a good idea to start considering medical equipment. So speaking with a primary care provider for a prescription for either a wheelchair or a specific type of bed if that's necessary. All right, so now that we've kind of touched on some of the general forms of management, we'll have Keith come in on Tai Chi.
Hi everyone, my name is Keith Fine. I'm a physical therapist and athletic trainer here at our Parksville location. Just going to talk about some treatment methods we're going to do, ways we can kind of work in physical therapy and to not only make it beneficial for exercise, to help slow down the progression of the disease, to gain better functional independence, and it's also going to be fun while we're at it. So talk about Tai Chi. So it's really just a bunch of slow, controlled movements, really about the mind-body connection. A lot of it's based in posture, muscular strength, deep, relaxed breathing. Really important also for balancing, and also as a relaxation method. The one problem that you'll see with some patients with Parkinson's disease is difficulty with multitasking. Doing these multiple movements, and you'll see this as we discuss other treatment methods as well, are really going to be helpful if we can continue to challenge the body and challenge the mind at the same time. So these sort of rhythmic, slow movements, while individually may seem relatively lighter or easier, combining them together is going to be challenging and beneficial for the patient, and also with having, like I mentioned, posture, strength, flexibility, and the ability to control breathing for tolerance of exercise, tolerance to walking up and down a flight of stairs, tolerance to walking to your doctor's appointment, or walking really anywhere really. And we'll go into voice training. So this is one thing that we do a lot here, is we talk very loud with patients with Parkinson's disease. As Ramneet mentioned, sometimes that akinesia or bradykinesia can affect not only the vocal cords, but the lips as well. So, if you or a loved one might have Parkinson's disease, and you might notice someone saying, "Hey, can you talk louder?" The brain is thinking we're speaking here. With a person with Parkinson's disease, you're actually going to be talking in a much, much softer volume. So how do we kind of bridge this gap? Is we're going to go, above and beyond, going above the screen here to kind of demonstrate how loud we would be talking, and not only about talking at a louder level, but more enunciation. Really opening the mouth wide when you're talking and really enunciating each and every word. So the whole goal of that is to go from here's where baseline normally would be, here's where baseline is with some patient with Parkinson's disease. Have you think you're training at this level, so we really fall back down to a much more speakable level that is common for most people. A big issue that happens with Parkinson's disease is patients will say, I'm stressed, I'm frustrated that my partner can't hear me, my children, my grandchildren, my friends can't hear me when I talk, and I feel like I'm talking normally, but because of that perception of larger movements that isn't actually existing, we're going to notice that talking a lot louder is actually going to sound normal to most people. And not only is it going to help with articulation of words and getting, being able to talk, but it's going to help with swallowing, improve facial expression, and just overall is going to improve that person's quality of life. Kind of the gold standard for this is done through Lee Silverman voice treatment. I attached the link onto here. They go specific courses where it really goes and says, hey, here's how we train it, here's how we enunciate it. And I think that the greatest part of this and the real true sell is they have these before and after videos of here's how the person talked prior to the training, and then afterwards, and it is remarkable. It seems like two different people. So next we're going to talk about amplitude training. Similar to talking, the body is going to move at a smaller amplitude of movement, similar to what Ramneet was saying with the shuffling pattern or the fascinating gait pattern. That is going to feel normal for the patient. They're going to think they're walking at a completely normal, pace, a completely normal height, a completely normal stride length. And for our friends who are here watching in New York, obviously there is not a sidewalk in New York that doesn't have a crack or something you have to watch out for. So if we're walking with a small amplitude, greatly improves the risk of tripping, of falling, of losing our balance. And that's obviously the big thing we really want to prevent here. But this has effects in so many other aspects, reaching for a cup of water, writing even. You'll see patients where they'll start out writing regular size letters, and by the time they're getting to the end of the sentence, the letters are almost ineligible, or you can't even see it in general. So the one thing about this also is it's going to require consistent application outside of therapy. Many times when I have patients first come in for an evaluation for Parkinson's disease, I'm walking with them and it looks like exaggerated movements, and the patient will oftentimes look at me and be like, well, that looks almost like you're doing too much. But similar to mentioning before with the voice treatment is we're going to aim for way up here So it makes the baseline more of a normal, there. Again, mentioned before, same thing with getting up and out of chairs, getting in and out of car, getting in and out of bathtub. The higher amplitude of movement we're going to train and teach the body is going to really help with the person going forward with their life. So I'm going to just demonstrate a couple exercises. So I'm just going to move the computer a little bit to the side here and kind of demonstrate some exercises that we'll do. And I think the first and most important one, let me just adjust this here, is walking. Walking is something we all have to do. It's incredibly important. You know, it's impossible to get around your apartment, impossible to really do anything without having a good form of walking. So I'll tell people multiple things. One's going to be when they're walking, get the hands spread real wide, is what I mentioned with writing. A lot of times that small movement, even as Brad Mead was talking about that, you know, pill rolling tremor. So we're going to have hands out. And when we're walking, we're going to do two things here. It's going to look kind of funny at first, but really lifting the arms and legs up as high as possible when they're walking here in the clinic. Same thing when you're out around the house, as high and as large as possible to train that body to continue to function at that high amplitude. If we're able to function at that high amplitude, we continue to train the body to perform that way. We continue to perform that way. We reduce the risk of a fascinating gait pattern. We reduce the risk of trips and falls. Another thing I like to demonstrate is getting in and out of a chair. So I have a stool right here. A lot of times with patients, when they're getting up, they'll have trouble kind of getting forward into it. And then when they get up, they might have to reach for something. So to help with the overall body positioning of that, you're going to instruct them nice wide foot base, lean forward, press up, stand up, and extend. Similar to the walking, my hands are spread out, working on getting you nice and open wide to prevent that like forward roll of the posture. Again, another demonstration is coming on up, spreading it out. So as you can see here, I'm moving at a large amplitude. I'm adjusting my posture, so I'm nice and wide open here. And I'm not rolled forward, I'm not hunched forward. My feet are wide and big. And again, it looks exaggerated, but that's the whole purpose. Another thing, we have like a computer mouse here. If you're going to reach for the computer mouse, a lot of people might slowly reach for it, or reach for a glass, or reach for a mug. And you can oftentimes see a kinetic tremor, which is a moving tremor, where you'll move and the hand will shake as it's moving. So to pick it up, you're going to reach at it, open up real large, grab it, and move it back. These are almost exaggerated type movements to really help to tell the person kind of, hey, this is how we really need to train the body. So we'll go back to the presentation and talk about other treatment methods here. If we can just get that pulled up. It's coming up here. Boxing. I think this is one of the more fun things. My patients that I've worked with really enjoy doing this. First and foremost, non-contact. Just want to let everybody know here. Usually I'll have my patients like you see on the picture there. Some will have the gloves on. I'll usually have the mitts, and we'll train, and it really, first of all, works the heart rate up. If you're looking at what's going to be best and most beneficial for patients with Parkinson's disease, if you go like a 0 to 10 scale, 0 meaning you're not exhausted at all, 10 meaning like you're about to pass out, we're really trying to function in that 7 to 8 range of feeling fatigued. So one of the best ways we can do this is working out the whole body. So this is not only going to improve endurance, strength, coordination. I mentioned before that ability to multitask is very important. We're going to add footwork drills into this. You're going to move, like I'll move the targets around and make, patients adjust and hit different heights, bringing it up high, bringing it up to the side. And it's not going to just help with that. It's going to be fun. It's going to really help your hand-eye coordination, the ability to multitask for sure. And same thing with talking about the amplitude is I'm not going to hold the mitt close to the face. You're really going to have to reach for it to help improve, again, not only your motion, but to help reduce the, the risk of tremors, rigidity, and all of that stuff. And I think it's going to get the heart rate up. It's going to be fun. We can add footwork to it. We can add punching bags to it, and I just think it's a lot of fun, not only for the patients, but even, for the clinicians, us here as well. Oh, we'll go into dancing. So I think dancing's something that is a really fun thing that people can do. And there's tons of different types of dancing that you can do. You can look even up onto the Parkinson's Foundation website, and they will give lists of classes where there's dance courses available, where there's anything where it can be from line dancing to ballroom dancing to salsa and bachata to really anything around those lines. And as you can see in the picture there, it gets everybody involved and engaged. And not only is that beneficial from the physical aspect to get engaged, but the psychosocial aspect, and especially we've seen with the pandemic, the importance of having that psychological and social connection with people. And I've had it with patients that are working with their significant other. One patient, the patient having Parkinson's, the significant other, usually the caretaker, just helping out. And it's just a lot of fun for the patients. And similar to everything else we've done and talked about here today, you're working on, hand-eye coordination, foot-eye coordination, the ability to move in all planes, not just forward, backwards, sideways, rotational. And for anybody who's danced knows it can be a good cardiovascular workout. And as I mentioned previously, keeping the high cardiovascular input is going to really help improve the motion for these patients, and also help out the posture, help out the tolerance to exercise, and help out their ability to continue with their daily life and be as independent as possible. Other things we can discuss as far as other workouts you can do. There's classes on yoga. There's classes, as we talked about, boxing, weightlifting. There's really just a litany of different pathways we can do. And I think that's one of the great things with physical and occupational therapy is each and every patient and each and every session for that patient is based on what does that patient want to get back to. And we can really tailor our expertise to make something that not only is going to be beneficial for the patient, but enjoyable, fun, and really get the best workout into this. And for the caregivers that are out there, your role in this is so important, not only to help to tell your loved one to talk louder, to move larger, but to engage into this and to really help with, again, not only that physical aspect, but the psychosocial aspect for both yourself and the patient. All right, we'll go to the next here.
All right, thank you, Ramneet. Thank you, Keith. So that concludes our presentation for this evening. We wanted to thank everyone for attending our webinar. We hope this was helpful in understanding some of the signs, symptoms, and treatment methods for Parkinson's disease. Again, if you or a family member are believed to have Parkinson's disease, it is best to contact your physician before starting an exercise program. So next, we're going to get into our Q&A portion of the webinar. So thank you for all the individuals who submitted questions. And Keith and Ramneet, I'm going to go ahead and start reading some questions for you. So our first question we had was, what would a PT or OT evaluation look like, and what can the patient expect during their first visit?
So for the first visit, a lot of it is just talking. Let's find out what some of the impairments that person is experiencing. There is a testing procedure called the UPDRS, which helps kind of go through all sorts of different physical, psychological, social aspects of the disease, so we can kind of tailor in to what is affecting this patient the most. So one of the things they talk about Parkinson's disease, and the nickname for it is the snowflake disease. It's every case really is individual of each other. There are some cardinal signs and symptoms, and similar to what Ramneet was mentioning, there's a lot of similarities for like, hey, these are the cardinal steps here, but everything's going to be a little different. So there's always going to be some form of walking analysis. There's going to be an analysis of if there is a tremor, an analysis of if there's any form of rigidity, the ability to stand and collect your balance. One of the tests we'll do is the patient will stand in front of me. I'll actually put my hands on their shoulders, pull them back towards me, and see how they correct themselves. If we know that, oh, wow, this person's having some issues with collecting their balance, we'll really work towards that. So really, it's a total body approach. It's not just, oh, we're going to look for these symptoms. We're going to treat each patient individually of what's most affecting them and then go through there.
Thank you, Keith. So our next question, how do you know if you have Parkinson's disease and it's not just age-related changes to do with balance, vertigo, and loss of muscle tone, etc.? What does the diagnosis process look like?
Great question. So one, just going back to the common symptoms, right? So if you're seeing not just loss of muscle tone, but you're also seeing loss of muscle tone in a very quick progressive method. So it's a progressive disease. Normally with aging, we do lose tone, but if you're losing it in 3 to 5 years, it might be indicative of an underlying disease process. Also, that other common symptoms, the tremors aren't usually seen in patients who are aging. So if that's seen even earlier in the disease, then it's something to be a little bit concerned about. The postural instability, even though it doesn't really start to present a little bit later, if you're seeing that they're having difficulty walking or taking steps or doing things that they were able to do without difficulty, it's probably something to consider. In terms of actual diagnosis, I don't believe that there's an actual test or diagnostic tool that exists to determine if they have Parkinson's disease. We do have that H&Y staging scale that we were talking about to see kind of where along the disease process they are. So earlier stages, if it's just affecting one side of the body, later stages if it's affecting both sides of the body, and whether they're able to stand without an assistive device, whether they're able to perform other activities in their day-to-day without assistance from others. So basically, just if it's occurring a lot faster than it should in the normal aging process, then something to consider.
And another thing just to add is if you believe you have any symptoms of Parkinson's disease or you or a loved one, set up an appointment with your physician, set up an appointment with a neurologist. They'll be commonly the ones who will diagnose these conditions. And again, they'll run through some of the testing that we'll do from a physical standpoint, but they'll also help with a lot of the other things. They can even do MRIs to see stuff into there as well. But overall, including the usage of a physician or a neurologist into this will be very helpful as well.
Thank you both. Our next question, can you slow the progression of Parkinson's disease if it is caught early on in the process?
So that's really a lot what we're trying to do here. And if you look at the staging of before and showing kind of that progression, that is not an absolute by any means. Exercise is really one of the best tools we have to slow down the progression of the disease, especially looking at if we work on posture and we work on balance and we work on ambulation, the decline is going to be significantly slower with use of therapy and use of other exercise and rehabilitative techniques.
So our next question, does daily exercise decrease the risk for developing Parkinson's?
That is not entirely sure yet. Again, as Ramneet mentioned, we're not 100% sure everything that causes Parkinson's disease. There are some correlations, not always is correlation equal causation, but definitely keeping up with exercises and keeping active. If you do end up becoming diagnosed with Parkinson's at some point, you will have a higher baseline of tolerance to exercise, ambulation, balance, cardiovascular endurance, which would potentially cause the decline to be less rapid.
Our next question, is dementia considered a part or a component of Parkinson's disease?
Um, Not too commonly. So dementia you might see with, Alzheimer's and others, but remember we were talking about loss of dopamine. So dopamine more affects the movement systems, the motor systems. I mean, it's possible that, it's different on a case-to-case basis, but dementia is not one of the more telltale signs of Parkinson's.
You can see a psychological response to Parkinson's disease. You might see people forgetting some things. It does not necessarily mean it's dementia per se, but there can be some psychological issues, difficulty remembering things that can kind of mask it, but it is more associated with Parkinson's and the loss of dopamine itself than actual dementia.
I remember we were talking about those side effects with medications. So it's possible that there's not dementia per se, but there are some cognitive deficits that are made a bit more visible due to the medications that they might be taking.
Along those lines, I think a good next question that we had was, are there typically side effects from the medications taken with Parkinson's?
Yeah. As with most medications, there are side effects. We didn't really go into much detail about all of them, but a few to consider: the cognitive deficits that we were talking about, confusion, fatigue. So things to keep in mind when you're sort of working with this patient. Don't overdo it if they're on medication, and then just common GI symptoms that you might experience with any medication, like nausea, vomiting, stuff like that.
One you will occasionally notice, for especially some of the dopa, so carbidopa, levodopa, as with a lot of medications, your body ends up getting used to the medication. It does take a higher dosage, so you can actually get which is called dyskinesia. So dyskinesia looks similar to a tremor, but it's more of a more rapid movement of the body. And you see a prolonged usage of the levodopa or carbidopa, usually, where it's like this curve and there's this golden zone in between where you're really getting the best dosage of the medication. But if you overshoot the medication as far as strength, there's this little part up top where there's actually a little more of a rapid movement that happens more with a prolonged usage of the levodopa and carbidopa medications.
Thank you. Our next question. I have heard that moving around aggressively in your sleep can be a sign of Parkinson's disease. Is this something that you have heard in the past?
Similarly to some of the cognitive aspects, there are multiple different motions that can happen. That could be something related to like a dyskinesia where you're moving a lot. There are thoughts of having very lucid dreams sometimes with Parkinson's disease, either before or after the medication, that could lead to that as well.
Thank you, Keith. Our next question, do essential tremors usually result in Parkinson's disease?
So essential tremors are usually ones that occur with movement. And with Parkinson's, we mostly see tremors at rest. And again, Keith was talking about how correlation does not equal causation. So just because a specific patient presents with a specific type of tremor, even if it is a resting tremor and not, the essential tremor, that doesn't necessarily mean that it's going to lead to Parkinson's disease or vice versa.
Awesome. Thank you, Ramneet. And our last question for the evening. Have you heard that exposure to heavy metals and or pesticides are a factor in developing Parkinson's disease? In questioning those I know with Parkinson's disease, they have often been in industries involving handling or frequent exposure to heavy metals.
I've seen some commercials where you'll see like the class action lawsuits that talk about, especially with pesticides and heavy metals. Personally, I do not know the prevalence or the relevancy associated with it. Like if you were prolonged usage of, exposure to a pesticide doesn't necessarily mean it was a percentage, but there is a correlation between heavy metal exposure, pesticide exposure that can be associated with many neurological conditions, one of them being Parkinson's disease.
All right, thank you, Keith and Ramneet. And I want to thank everyone for attending tonight and for all of your thoughtful questions. We hope today's talk was valuable and that you learned more about how physical therapy can assist in the management of Parkinson's disease. If we didn't get to your question, we will do our best to reach out to you directly afterwards. As a reminder, your presenters for today were Keith Find and Ramneet Manri, both located here at our clinic in Park Slope, Brooklyn. Please jot down their contact info so you can reach out to them directly with any further questions and/or to schedule an appointment. And again, I was your host, Eli Lamberson. I'm a physical therapist and our assistant clinical director here at Park Slope. Kathleen O'Donnell Pickert was our Q&A moderator, and she is an occupational therapist and certified hand therapist with Spear Live. Feel free to reach out to myself or Kathleen as well with any questions, as we are happy to facilitate getting you set up with one of our great therapists. At Spear, we treat an array of conditions from head to toe, and as a reminder, we're open for in-person visits as well as for telehealth sessions. Should you feel that you could benefit from some individualized guidance and treatment, please don't hesitate to reach out to any one of us individually, and we will personally coordinate you being set up with one of our team members for an evaluation. And lastly, we will be continuing our webinar series into 2022, covering a variety of topics. We look forward to seeing you there. Please follow us on social media and/or check your inboxes to learn more about our upcoming topics and the schedule. Thank you all very much for spending time with us today. We hope you enjoyed our webinar and we wish you all the best.